not you. I was just making a joke. Okay, thanks
That's why they
everybody.
keep calling you mate all the time?
Mate, yeah, they call me mate.
Oh, we had two of them in our training.
So thanks.
They were
What's that?
awesome.
Thanks everybody for coming. And we're going to talk about cervical stenosis today. And I think the best way to go over a topic is to show a relevant case, because when you know a case, you'll never forget it. And a most recent one too. Yeah, if I show a case from 5 years ago, I forget everything. My memory's getting, as I get older, my memory's getting worse. But the patient I did last week, I always remember, like, everything about. So let's go over this case. It's an interesting one too. It's a 55-year-old woman who presented to the emergency room November 15th of last month, of actually November, sorry, to the emergency room with left upper extremity weakness, acute onset. And she also had pain and numbness in the superior anterior part of her chest wall, down her left shoulder to the anterior arm to her elbow, not past that. And she could not use her left hand. So she thought she was having a stroke. She was very worried about it. She has high blood pressure and high lipids, so she is at risk for that, African American woman. So she went to the emergency room. She was admitted to medicine, had a CT of her head, which was normal, and they thought it's probably coming from her neck, cervical spine, and it was. And they consulted us. She's a right-hand dominant Frito-Lay worker, so she works at the plant up north, and so she uses her hands all the time. Her job is like putting, I think, things into boxes, things like that. She works on the assembly line. She had a gastric bypass at Havre de Grace and lost 150 pounds last year. So, kind of interesting. And her motor strength was 4 out of 5 in her left upper extremity in every muscle group. So, the deltoids, elbow flexion extension, wrist flexion extension, and interosseous, 4 out of 5 motor. And she did have paresthesias in the dorsum of her hand. So that was, neurologically, those were her only symptoms. And here are the x-rays. She's got these arthritic changes at C5, C6, and this bone that goes across the front of the disc space. You see that? And at C4, C5, see how it's flexing forwards and it's not lined up? She's got spondylolisthesis there too. So these big she's got the osteophytes from C5 to C7. So these osteophytes make it stiff in general when you have these big spurs. And can you just think of a story why this level would be shifting abnormally like that? Can you just give an idea? Above the first level above a stiff segment?
Above the...
Yeah, so this area is stiff.
Yeah.
So because
it's
this...
it's like a fusion.
It's like a fusion.
With the weakness above and below.
Yeah, yeah. So you get adjacent segment degeneration and motion above a very stiff segment. So that's what you can understand. So this is obviously a problem here at C4,
Oh, is there
C5.
spondylolysis with it? It looks like there's a line.
I'll show you. So here's on the side is the left side is the flexion view. You can see that the spondylolisthesis, and when she's upright, it reduces somewhat. So there's significant motion there. Here's the MRI, and we're focusing at this segment. You can see if there's motion there, you can see how it would compress the spinal cord. And this level looks totally normal, doesn't it? Looks plenty of room in the spinal canal. The disc looks completely normal. And then this one has, hey Doug, good morning. This C6, C7 has both posterior and anterior disc bulging. So Doug, just to review, 55-year-old woman presented to the emergency room last month, November, with left upper extremity weakness in all muscle groups, deltoids. Hey Megan, come in. Sorry about that. Left upper extremity weakness, deltoids, elbow flexion extension, wrist flexion extension, interosseous. Her x-rays show degenerative changes from C5 to C7, and at C4, C5 there's a grade 2 spondylolisthesis, so left upper extremity weakness. And the flexion extension views show gross motion at C4, C5 above this previous fusion. And we're just going over the MRI, which shows at the same level, C4, C5, there's definite stenosis. And there's also arthritic changes, some mild posterior ligamentum flavum hypertrophy, and also disc changes that are abnormal anteriorly and posteriorly at C6, C7. But
she had a 5-6 fusion?
She did not have a 5-6 fusion. Why do you say that?
Oh, I thought
C5, C6 looks totally normal, doesn't it?
Right. As does 4-3.
As this, yeah, 3-4. So here's another view. That doesn't add much. Now look at the CAT scan, Doug. Remember the disc looked totally normal? The C5, C6 disc looked totally normal?
Yeah.
Can you give me a reason why you think that could be the case? If looking at the CAT scan?
Yeah, she's basically fused. She's got
Mhm.
a fusion, a bony fusion.
See
So
that,
she has
guys?
no motion.
So she's got that autofusion. This level looks arthritic. It's got that big spur. So at C4, C5, there's no spur. So you can see how that level would be especially at risk to develop the spondylolisthesis because it's the first motion segment above two very stiff segments. You see that? So the CAT scan kind of proved that, the anatomy a little better there. And this gives you another view of how she's solidly fused anteriorly.
You can make your post-ops look like that.
I know,
It'd be
I know,
beautiful.
I know. When you don't want it to fuse, they fuse, and when they want it to fuse, they don't fuse. That's how people are. They always do the opposite. And here's an oblique view, which just gives you an idea. Here's the fusion again, and it just shows the foramina of the hole where the nerves run out. Doesn't add too much. So here's the axial cuts. So remember Doug said C3, C4 look totally normal. So here's an axial cut through the spinal cord. Looks totally normal. Doug, I know you're not a radiologist, and I do appreciate you coming to the spine conference because you're very nice to talk to and you're intelligent. But what do you...
Gonna buy me a drink test or something.
Turn
So-
the lights down.
No, don't turn them out. We'll get tired. So we'll go to sleep. This is C3, C4. How would you describe the spinal cord at C4, C5? Remember, that's the same level we have the spondylolisthesis.
It looks compressed in the AP.
Yeah, see that? So the front or the anterior portion of the spinal cord is flattened compared to C3, C4, and stenotic. Remember C5, C6? That's the level that we said is fused on the CAT scan. What do you think here?
That looks less compressed. It looks like there's a little bit more epidural fat.
So you got some epidural fluid in front, and it looks very similar to 3-4, doesn't it?
Yeah.
And how about 6-7?
Again, you can see some AP flattening.
So the canal is definitely smaller. The spinal cord looks smaller here
Right.
versus here.
Right.
And this stuff I think is some ligamentum flavum thickening of posteriorly, and you can see that on the on this view here. See the ligamentum flavum is slightly hypertrophic compared to the other levels. So I think that and the bulging disc is contributing to the fact that her spinal canal is tight at C6, C7, and you can see it somewhat on the axial cut. See it right there. So what should we do? So she failed non-operative treatment, Doug, and she wants a surgery. Her arm doesn't work. She's a Frito-Lay worker, so she needs both hands to work at work. She puts together things in boxes. She's 55 years old. She's not retirement age. So she's. Let's ask. I'm sorry if you don't mind me interrupting. Let's ask Megan. What would you do with her, Megan? Our resident physical therapist.
No, I missed the first part. You said
She's 55 years old. She has left upper extremity weakness, numbness, paresthesias, and it's been a month. She presented November 15th, and she came back to me in the office December. And she said, "I'd like to try some physical therapy." So I wrote a letter to Megan. Megan, please make this woman better. What can you do for her?
Well, I would first focus on posture. It's probably forward head posture around the shoulders, whereby stretching pecs, strengthening anterior, stretching posterior, and then I would try some manual mobilizations, maybe just to get
What kind of posture should you assume if you have a neck problem?
retracted neck.
So let's say, can you move a little bit? Can you show on Cami, what would you do? Make her neck better. Yeah, come on. We're on YouTube.
Make your lower back
Go ahead.
arch, and then pull your chin back. There we go. Keep your shoulders back.
That's it. So you teach the people. Now, see, I have a hard time doing that. What if I say I just can't do it? I get tired.
Then I give everybody a lumbar roll. You take a towel roll at home, sit all the way back at the back of the chair, lean forward, shove the towel down, and sit up. It creates your lumbar lordosis, which in turn helps you.
With the hope that the posture maybe will help.
Right, because if you have that cueing back there at the lumbar region, then if you slouch, you're just forward and uncomfortable.
Okay,
And
that's
I show
me.
them, what happens here, that, they're standing like this all day, so they have to do this, so you're crunching down everything that's painful.
Okay, so what?
From there.
Okay,
Soft
so
tissue work.
okay, soft tissue work. Well, I did all that, and she didn't get better. So now she comes to Doug. Doug, what do you want to do for her? Two levels of stenosis: C4, C5, C6, C7, and C.
And she's got no neurologic signs. She just
She
has
does. She does. She has weakness.
She has weakness?
4 out of 5 motor weakness in all muscle groups in the left upper extremity.
all muscle groups.
All muscle groups. Deltoids, elbow flexing extension, wrist flexing extension. So if you say the nerve roots, it's from C5 to C7, all of them. And she has this dynamic spondylolisthesis at C4, C5.
Yep. Well, decompressing her is going to help her symptoms in the short run. The problem is, you decompress her, you're going to destabilize her. So she needs to be decompressed to give relief of her neurologic symptoms, and then she needs to be stabilized, and that would probably be a fusion.
Okay.
And unfortunately, she has 2 segments with a normal intercalary segment. So,
Right.
the option would, the stupid option would be to fuse one segment and then fuse the other segment, or fuse the whole deal.
There is an implant where you can do that now very easily. It's a cage with 2 screws attached to it. I don't use it, but so that's interesting. So,
But being a purist or something, a lot of people, you see this much more than I do, but a lot of people have bad looking spines. They have spines with disc disease or degeneration of multiple levels.
right.
And I've seen a lot of people that have had multiple level fusions, and they never get better. In fact, they get worse. Or it's like this, was it neurosurgical? I forget what we used to say the phrase was. But they have
Failed
they have
spine
a
syndrome.
decompression, so then they get the next level, and then they get the next
Adjacent
level.
segment degeneration, yeah.
But
So
it's just like these people get multiple operative, and I think the problem is they never got the right operation to begin with.
it's
So-
possible, but you don't blame a cardiologist for worsening cardiac disease, right? So if someone has multiple stents, you don't say bad cardiologist. You blame the disease. For some reason, people always blame spine surgeons for progression of disease. It's a little bit not fair. You see what I'm saying?
I'm not saying that they get blamed for progression of disease. I'm saying that they get blamed for doing the wrong procedure for disease. It's kind of like when I was a resident, we used to have a lot of traumatic spine injuries, and the neurosurgeons would decompress them always, but never stabilize them.
Right.
So,
But that's that doesn't happen anymore because
my
that's
point
like a
is it gets
15
rid of the problem, but it creates other problems. And I think decompressing this spine would get rid of the problem. But
you're absolutely right. But what's changed? See, you're not in the field of spine. What's changed now is all neurosurgeons fuse.
everybody fuses.
Everybody fuses
Sure.
now.
They figured
So
out you get paid a lot for that.
you get paid 3 times as much. So
And you can come back, a year later and do something again.
Right.
It's like an annuity.
right. So it doesn't happen. That
Or
doesn't
you get
happen
scar
anymore.
tissue.
Well, yeah, or adjacent
All right, let's
secretaries.
move on.
So we'll move on. So everything that Doug said, I agreed with and is right. And I chose to fuse anteriorly, and the spondylolisthesis reduced in the operating room with resection of the entire disc, and then distraction with the Casper pin, which is the standard way that I do these cases, and then placement of the graft. Also, when I tightened the screws, I did not tighten this screw. So let's say these screws weren't here, and I tightened these sequentially, these 4 screws very slowly, like you do a lug nuts on a car, and that slowly reduced the spondylolisthesis as well. Do you get my drift? I didn't take extra.
Pushes the vertebral body back.
Right, push that body back slowly through the screws, and it did work somewhat. I mean, it's not a big deal, but
Indirect reduction.
right, right, but it worked. And here's post-op before she went home. Interestingly, the next day, arm was totally normal, completely. So I think this patient, the reason why she was weak is from the instability. I mean, her spinal cord was undergoing a incomplete spinal cord injury from the C4, C5 spondylolisthesis. I didn't do anything to C5, C6 intraop. There was bridging bone. So I figure if it's fused, all I can do is cause trouble by doing anything. So I just left it alone, but I did bridge it with the plate. So just I'm just going to go over some cervical. So any questions about that case? That's like an illustrative case.
So where was her stenosis what you think. You know, you say her whole arm, but her
C4,
whole
C5.
arm- C4, C5.
I think that's the vast majority
It
of her
was just
symptoms.
on the left side,
Yeah,
just on one side.
I don't know why she just presented like that.
So, I mean, that's more of a case for nerve root impairment rather than,
If it's C4, C5, let me show you something. If it's C4, C5, it should classically be C5 root. And the C5 root is right here on the left. So if it was a C5 root purely, it should just be deltoid, the biceps tendon reflex, some elbow flexion, half of elbow flexion, and sensation in the lateral aspect of her arm. That is where she felt the paresthesias and sensation. And she did have motor weakness in the deltoid, but she also had elbow flexion weakness, which could be contributed to C5, but she also had elbow extension weakness, which should not be C5. Elbow extension is C7. And she did have wrist flexion extension and interossei weakness, which should not be C5. Interossei is C8. Extension of the wrist is C6. Flexion of the wrist is C7. So she did not present classically. So why, I don't know. It could just be pain. So if an extremity hurts, you shut down the whole extremity because you don't want to mess with it. And if you're a little bit apprehensive, you know the exam's not normal. Or it could be an incomplete spinal cord
I
injury.
mean, technically, if you're saying it was a central disc problem, then it should have been, bilateral
Should be bilateral.
extremities and/or,
Right.
everything distal to that. So it sounds
Should
like
be.
her exam, it was more like a one-sided root.
It probably was a root problem with some apprehension. It doesn't make sense. Okay, so just the history of every patient. I characterize the pain, what provokes it, palliates it, quality, region, severity, timing, and for a neurological exam, weakness, numbness, ataxia, dexterity. She did have dexterity problems. She couldn't handle her hand. She couldn't handle the things at work at Frito-Lay. I can just go over the basic issues we talked about is the spinal canal. And this is what a normal cervical spine should look like. And you see how the spinal cord has plenty of room at every single level. And there should be plenty of spinal fluid about the spinal cord on the axial cut. And you can also do a CT myelogram to assess the anatomy. And the CT myelogram is great for differentiating osteophytes versus soft disc. So you can see here's the junction of the bone, and you can see this soft material, which most likely could be a disc, but also could be cartilage that hasn't calcified yet as well. So that's where the CT myelogram is helpful. And just for anatomical, here's purposes. Here's the spinal canal. Here's the posterior vertebral body, and where the disc is, you can also get osteophytes going backwards into the spinal cord. And the main problem in the cervical spine are these joints called the uncus or the uncinate process, and these things get big in people, and it can compress the nerve root. She had this patient. I'll show you. She had big uncuses too. Show you where the uncus gets big. She doesn't have a big uncus, but it usually gets big right here. That wasn't her main problem. That was my mistake. But that's where the uncus is, and it hits the nerve root laterally. And intraoperatively, you have to remove that. It always comes from the inferior aspect of the disc. You have to remove this spur, piece of bone. But you have to be careful while you're removing that spur. The spur is right here. Look what's right next to it, the vertebral artery. But the artery is usually way anterior to where the spur is, intraop. So you have to be careful with your kerosene not to hit the vertebral artery. If you hit the vertebral artery, it's a big problem. You could bleed to death. You could get a stroke. So, just in general, the disease processes are degenerative, infectious, metabolic, traumatic, inflammatory, metastatic, and iatrogenic. You guys remember that from a medical school. And this is a degenerative process. And you see here how the uncus becomes an osteophyte and compresses into the neural foramen, or the hole where the nerve runs out. I never say foramen anymore. I would tell patients the hole where the nerve runs out, because they can they can understand that. I stopped using all medical
Welcome to
terminology.
Harford County.
Yeah, they don't understand. And you can see here's the nerve and here's the vertebral artery. It's right next to it. So other aspects of neurological exam on physical exam is gait. I try to watch everybody walk. Do you do that, Doug, in your office? You get a lot of information watching people walk.
I watch every disability exam walk,
Do you? Yeah.
in the office and out the office, sometimes out into their car.
Yeah, I bet. I do too. Just if someone has a limp, I watch them. And you can. I've diagnosed neurological strokes. You know, people didn't realize they had a stroke because they have the circumduction gait, and you only see it when they go up and down the hall. So I also did a pediatric fellowship, so I'm used to watching kids walk. We used to do that all the time. You remember in peds, you used to always do that, watching kids walk. You can get a lot of understanding from people's walk. So gait, other things, motor, sensory, reflexes, fine motor, and cranial nerve exam. And this is if you assume this position, all the dermatomes line up. Look at this: C2, C3, 4, 5, 6, 7. Hey, Joanne. Good morning.
Sorry, I guess I'm turned around
No,
upstairs.
no problem. T1. So if you forget how the dermatomes are, if you can remember this picture, they all line up perfectly. So it's a good way to remember your dermatomes. And we went over the dermatome function. The other aspect of the exam is you can imagine if you push on someone's head. This is out of Hoppenfeld's textbook. I copied it. You push on someone's head, it compresses the foramen. It can give people symptoms. I never do this. I never do things that provoke pain because people get really angry. But you can do that. And the other thing is like cervical pain always refers to the scapula. Do you find that to be the case, Doug, or Megan? You think so?
9 times out of 10.
Yeah, that's where they describe the pain. And the other thing is, if you stick a needle into the facet and push saline into that, this is where people feel pain. And this is a study done by Bogduk in 1990. He took volunteers and pushed saline into the facet, and this is where they felt the pain. And this is where people come in and complain of pain as well. So it could very well be facet pain. And so probably a lot of people you see, Doug, for shoulder problems, it could be cervical problems from the facets. If you're worried about the spinal cord, you can very easily get the Asia spinal cord exam on Google, and you can document that in the emergency room. So I always tell the emergency room physicians, print it out and document it, but they never do it. Okay, so any other questions about anything we said? Anybody? Okay, the other thing is that radiculopathy can masquerade as other things. So what can masquerade as cervical radiculopathy? So something that you think is cervical radiculopathy, in fact, is something else. And this is like just a list of these things. A brachial plexopathy, I've seen about 4 or 5 in practice, let's say, in like the 13 years. Have you seen many? I saw a youngster, a football player who came, and they thought he had a stinger. In fact, it was a viral brachial plexopathy. He lost all function of his arm. Very scary, but it came back. I've seen a couple like middle-aged men. Have you ever seen any of those cases?
Yeah, help me out. There's an eponym for that.
I forget now.
It's going to come to me in a minute. But a lot of times, one guy that I saw about 2 or 3 years ago, what happened is his PCP ordered an MRI of his shoulder, and he basically had complete denervation of his entire shoulder girdle. But he had a normal C-spine. So basically he had this, and there's an eponym for it. It's basically like a 3-month...
Parsonage?
Parsonage-Turner syndrome.
Parsonage-Turner syndrome, yeah.
Right, and it's sort of like a viral or an undetermined idiopathic short-term denervation, which usually returns. But I think the problem is it gets mistaken or misdiagnosed for something else, or it's not appreciated.
Yeah,
Some
and
people get surgery for it or something like that.
They get-
But it's
yeah.
a non-surgical issue.
they get a thoracic outlet surgery, or it's very scary when the kids. I had a child, so it's very scary. And sometimes I think you can get an MRI scan which can show inflammation of the brachial
Shows like
plexus.
inflammation, diffuse muscle edema.
Right.
And you know, the guy that I was dealing with worked at the proving ground, so you're always sort of thinking, does this guy have some kind of toxin exposure or something?
Right.
You know,
Occupational
or
exposure.
myopathy or
Yeah.
what, but he got better, but he was like one of these guys, kind of looked like Charles Manson. You know, had a beard like this, and lived in a. It was tough to get a history from him, but Parsonage-Turner syndrome.
That's standard for Harford County. Big beard.
in my climate, but it's a certain group.
The other thing I worry about is it could be a tumor pushing on the brachial plexus. So I don't know if you're worried about that, you need to get an MRI, especially if they're a smoker or something, or a CAT scan. So the other thing is the rotator cuff or impingement can.
And what's that? You're talking about like Pankos syndrome,
Right.
Yeah.
A C5 radiculopathy, which is pain to the acromion and lateral aspect of the arm, could be a rotator cuff or impingement. And the way I differentiate it is if they can lift their arm up with no pain, it's not rotator cuff. C6, C7, pain that runs into your middle finger and hand, could be carpal tunnel syndrome. C7, palsy, it could be a posterior interosseous nerve problem. That's very rare. It's usually like trauma, or you get a history of trauma for that, posterior interosseous nerve behind the elbow. Anterior interosseous nerve, occipital tunnel, can be C8. So I see a lot of that actually, fifth finger pain and numbness. I have bilateral. I personally, I know this is not all about me, but I personally have C8 radiculopathy from an injury. I had a dislocation of my elbow, and my fifth finger is always numb, and I have to keep my elbow straight. It's very common. I see it all the time in patients, cubital tunnel syndrome. And my rule of thumb is I tell them go to Dick's and get an elbow pad and turn it around backwards at night, and just do that. Just rest it at night.
So their elbows stay straight.
Yeah, so the elbow stays straight to rest the nerve. Do you have any other things you do, Doug, for cubital tunnel
I
syndrome?
give them elbow pads also. There's I see a lot of like traumatic ones, like these construction guys or something. They get a bat, and there used to be like a spider. It was tough. I used to give them a spider elbow pad. It was sort of like one of these big ones, and then you can obviously decompress them when they're chronic.
Yeah. Yeah, that's if they fail. I send them to someone
If
who
they
does
have a
that.
positive EMG, I decompress them. But if they just have symptoms, I try to treat them non-operatively for at least a couple of months.
Okay. Other things are a double crush syndrome. So someone can have both cervical radiculopathy and lower extremity compression, and everything's accentuated. People can have angina, which I've never diagnosed actually, chest pain. I mean, I always think they have a heart attack, but they don't. They could have complex regional pain syndrome, RSD, or thoracic outlet syndrome. Other things, and I'll go through this real quickly. They could have ALS, Lou Gehrig's disease. They could have myelitis. They should be sick from that. Multiple sclerosis. If I don't know what something is, I send them for neuroconsult. Multiple sclerosis. Some other demyelinating condition, something in their brain, intracranial pathology. Syringomyelia is always possible, and I'm always thinking about that in children when they have unusual presentations. Chiari malformation, OPLL, I see all the time. Ossification of the posterior longitudinal ligament. It's not just associated with Japanese people. Yeah, Asians. I see a lot in African American people. I see a lot of normal Northern European descent people in Harford County. And the other thing could be ankylosing spondylitis. So these are just a couple. Tell everybody what these tests are, Doug. How about the Job relocation test for shoulder pain? Do you ever do that? For throwers? For shoulder pain, for unusual shoulder pain? It's just you put them in the position where they have pain and they're subluxating anteriorly, and then you push down on the humerus, and that makes the pain better. So that's a test to see if people are loose in their shoulder. It's usually kids and throwers that have shoulder pain. The forward elevation test. I call it the near forward elevation test. Put the hand on the scapula, lift the arm up, and if that causes pain, it's impingement pain. And is this the Hawkins test, internal rotation and abduction for the shoulder? And adduction should be the AC joint. So these are like just generalized tests to see if it's shoulder pain. Can you add anything to Doug or Megan?
I'll do full can.
What?
Full can. Less than
What is that?
impingement, rotator cuff tear, if they can hold it, scaption.
Show me what you do.
30 degrees off the lateral.
Uh huh.
And then just press down.
Press down,
They can
and
hold
that.
it. If they can't hold it,
That's That's a rotator cuff.
That's rotator cuff tear. Sometimes they used to say do it this way, but the
That's
studies
that's
say
how I do. Is that the old way? That's how I
that's the
ask
old
patients
way.
to do. Yeah,
And
lift up.
Have you seen the research out that it doesn't really matter?
It doesn't matter if hand up or down.
Hand up or down.
Okay.
Empty can,
I learned
empty
something
can.
today. All right. So those are tests to differentiate shoulder impingement versus cervical spine.
I always take their pulses too because the tests are named after me, the Wright and the Allen test. And I always take their pulses and then I, elevate their arms to see to make sure that they
How about the airplane? Did you invent that?
That was a cousin.
That was a cousin.
Oh.
So here are some of these tests we talk about. The other thing is if they can put their hand on their back and lift backwards, it tests this subscapularis. And I also ask people to touch their buttocks with their hand to make sure they don't have a frozen shoulder. Because if they don't, then I start thinking they have a frozen shoulder, decreased range of motion in all planes of the shoulder. I've diagnosed many frozen shoulders that come to me for neck problems. What do you do for frozen shoulder? Megan, what do you do for frozen shoulders?
I mobilize and stretch a lot. And
Stretch.
Mobilize and stretch, mobilize and stretch.
How about you, Doug? You stick needles in them? No.
Very rare.
Manipulate them?
Excuse me?
Manipulate them?
The only ones I tend to manipulate are diabetics, but typically a frozen shoulder in my practice is a female middle-aged female person who has sort of an atraumatic, no injury at all. She just says my shoulder is stiff, and you examine her and she's stiff in all planes but no injury. And it tends to take it usually responds well to therapy, but it tends to take a long, long time for therapy. It's not one of these, get better in it's 4 months, 3 or 4 months.
I tell everybody it's going to be a year.
And then I've had a couple of people that, get better, and then a year later they come back with the opposite shoulder, same deal, I have the same thing. There are a lot of people that are very aggressive, a lot of people will inject them, they're talking about, arthroscopic, joint dilatation, you go in there and you try to blow up their joint and manipulate them, but...
Or cut the capsule.
Yeah, I'm not so big on that, but, diabetics, there's a lot of diabetics get that too, and it's sort of a relationship with neuropathy. Most people say they sort of end up the same way. There's nothing you should do special for them, but and then I have I did manipulate a guy just recently who was post-traumatic, who had a humerus fracture, and sometimes if you treat like an elbow or shoulder or something like that, he was sort of a diabetic, had a humerus fracture, his fracture healed, but his shoulder ended up stiff, and I did manipulate him once or twice.
We just reviewed a study on how to really treat frozen shoulder as a therapist, and the studies show that they get greater benefit from aggressive mobilizations and stretching and home exercises, and less with the what we call is just good feeling stuff, the ultrasound, massage, and heat.
Okay, these are just some depictions of just range of motion of the shoulder and head to take the pulse away to see if it's thoracic outlet syndrome. There's a bunch of different tests. So the treatments are for cervical radiculopathy, educate the patient. You've got a compressed nerve. I'm frozen.
Do you have packs on?
Hold on. No. You had a case? Educate the patient. Reassure them. Every patient that comes through, I hold their hands and talk to them, look them right in the eyes and talk to them that they have a problem. Everything's going to be okay. Medicines like steroids, ibuprofens, pain pills, muscle relaxers, sugar pills.
Is that a real person?
That's me in college. I used to lift weights.
Dermatofibrosis.
That explains a lot.
That's the problem with ibuprofen these days is they cause all sorts of problems: GI bleeds, renal failure, high blood pressure, heart attacks, cardiac risks.
I'm convinced in my 20-year career I've saved more people from having cardiac events by giving them ibuprofen now.
You think it helps? Cardioprotective?
Sure, absolutely. It's an anti-inflammatory, and that's.
Maybe aspirin. I was thinking maybe I should give everybody aspirin. And everybody's on Plavix these days. And I'm always in Coumadin. I'm always worried they're going to get a bleed.
I tell people that they're all the same things. Anti-inflammatories are all the same things.
Okay.
It's like ice cream. Some people like vanilla, some people like chocolate, but they're all anti-inflammatories. They're all antiplatelets.
I like the ice cream analogy. Rest and rest a little bit. Maybe give them a collar. Although I don't like giving out collars because I don't want people to think they're a sick person. I want them just to get back to their lives. Physical therapies we talked about with Megan. The other thing, the important thing is fear avoidance behavior. Is I try to encourage. I mean, this is just my opinion. I try to encourage people to get back to their lives. That pain doesn't mean you're going to die. You're not going to be paralyzed. It's not going to be a catastrophe. Don't just get back to your lives. That's the way. Not to focus on the disease process. The other thing is, you can diagnose both depression and anxiety, which probably all of us have a little bit since the middle of the winter now. Seasonal affective depressive disorder, and that can complicate matters. And like Doug said, actually, Joanne, how often do you see these processes, and do you think they're very common? This is Bowden's article from 1990, which showed it's in normal volunteers that have never had pain, and these are pretty young people, 40 years, because that's about my age. These are very young people. They had 16% of disc narrowing, degenerative disc disease, and 37%.
Absolutely, we see it all the time. It's like very common. I mean, yeah.
So it doesn't necessarily mean that it's a pathologic process. It could just be normal aging.
Absolutely.
Just a couple. This is just a couple of things. In 2009, the cost of an X-ray of the cervical spine was $100, and the interpretation is $175. The MRI in 2009 cost $377, the interpretation $175, and the CAT scan cost $246, interpretation $175. So it's just a rule of thumb what these tests cost.
So the X-ray interpretation was the same as the
Same,
CAT scan
every single one.
interpretation?
X-ray versus MR versus.
Yeah, they're all the same. I don't know if they're still this. That was in 2009 when I called. I said, I'm paying cash out of my pocket. What's it going to cost?
Who'd you call?
Upper Chesapeake Radiology.
MRI in 2011 is 353.
353? So it went down.
I don't know what the
There's a lot of
interpretation is.
competition.
For cash?
For that
That's
kind of
interesting.
normal
I was just
type of
353.
people
I
looking
thought
normal,
it was
just
like
be
1,000
degenerate. Have you ever
minimum.
said to your patient, my spine probably looks worse? I mean, have you ever?
I don't say that. I used to say that a little bit, but people, I don't like saying that because people feel that if I say that, I'm not taking them seriously,
Yeah.
and it's a big complaint that patients want to be taken seriously that they have a problem. So I try not saying that.
But if
So-
you looked at your own spine and said, I mean, this is degenerate. I mean, you don't have pain, but
I don't say that. Usually, what I say is that there's three factors that go into this part of the normal aging process. Although I have seen patients 90 years old that had normal MRIs, and totally normal MRIs. So it's not all aging. I see kids with the same problem. So there's some familiar predisposition, and I also, like Doug says, I see workers with the problem who clearly had something hit their head and had a huge acute disc herniation. So it's three things: injuries, familial predisposition, and age. But they're not all, they're separate factors. These are just depictions of. I think that's it. You can do pain management or surgery. Now I have like a ton of cases, but we're kind of running out of time. So, do you want to go over a case, or you guys want to ask a question or comments?
Yeah, I've got one question. Change it. The lumbar spine,
All right.
the SI joint articulation. What do you call it when the transverse process articulates with the sacrum?
I usually say sacralization of the transverse process.
Yeah, but there's a term because some people have like asymmetric
There's a word. A lot of people make a big deal about that.
tonsillitis syndrome or something like
There's a
that.
couple things. Yeah, there's a couple things. Also, a lot of people say that if the L5 vertebral body is deep set within the pelvis, some people have a very shallow L5. So L5, the pelvis is flat, the top of the pelvis is flat, and L5 is high, and that's more mobile. But if your L5 is deep into your pelvis, that's another factor people say. And if it's fused, it doesn't move. And some people have it ipsilateral.
Like a
protrusion, or they have, you know, a transverse priority, but you can, there's also a developmental condition where they develop, impingement of the transverse process.
Yeah, yeah. Some people say that. I'm not sure.
Okay. I think your numbers are off. I thought an MRI was like $1,000.
No, I was right on. Actually, I was high. These are cash payments. These are not.
Yeah, because insurance, it's like $1,000. I mean, they bill much more than that.
Oh yeah, this is the cash.
Well, they don't. Well, I don't know. They collect half of it, you know.
All right, let's do just one more case and then we'll finish up. Oh man. Sorry guys.
That's a deal. It's just under $400.
There's a lot of competition.
But I thought the hospital's got a higher rate
Well,
than.
That's inpatient. It's only inpatient activity. Outpatient activity, we have to, it's
Oh yeah,
more
outpatient.
competitive.
Yeah, outpatient.
So
Really?
outpatient.
All right, Joanne, you're up to bat. There's a 29-year-old man with right dorsal forearm pain. What do you see?
Typically very high.
Anything specific?
Inpatient.
Flexion and extension views.
Through the ER.
Look pretty normal.
As long as it's
I would just
all that's outpatient.
venture to say that I think that's it. At the last image on the bottom, at the so that's T3 at 3-4. The facets are potentially perched, but I'm not sure.
Okay, but it looks totally normal here.
Otherwise, yeah.
So you would see it here too. This is the oblique view, so it looks this normal. All right, how about the MRI?
So
Right dorsal forearm pain.
at C5-6, you have a focal disc bulge, most likely.
Mhm. This is going backwards into the spinal canal there. How about here?
Again, the same thing. I would say probably would like to look at the axial images, but probably causing a mild.
Sure, absolutely. For you, definitely, you can have axials. Here are the axials that you want.
Okay.
This is C5, C6. This is C6, C7.
So at C5, C6, you have some bright increased T2 signal within the posterior aspect of that
Mhm.
disc, which is causing some mild central stenosis.
So it's bright. Does that mean it's an osteophyte if it's
no,
bright?
I would say it's probably more disc and acute
Mhm.
than
Chronic and
Chronic,
ossified?
yes.
Okay. So you'd say probable acute on the basis that it's bright, right C5-6 disc herniation. And how about C6-7? Chronic left-sided?
more likely chronic. I mean, but again, it's so obviously clinical. And I try to word it as much as possible to let you have as much latitude as possible. But
Uh-huh.
yes, this is more likely chronic. It's dark. It's a disc osteophyte complex. There's less mass effect upon the ventral aspect of the cord.
Uh-huh.
The left-hand image, the right ventral aspect of the cord is flattened and mildly indented.
But why does a cord look, I mean, that looks flattened to me, but there's CSF there. Why is that?
It is. It could be chronic. It could be this is one static picture, and over time, when the patient is moving, etc., it may.
So when he stands up, it's hitting his cord, and that's why it's all crooked looking?
That's a good theory. I don't know. I can't answer that question.
Okay.
Why it looks like that?
I don't know either. I'm just asking.
I don't know, but I mean, cords do tend to start looking flat at levels where you have some stenosis.
Some pathology.
over time, and people don't necessarily have pain where the cord's flat.
Okay.
But
Okay, so C5, C6, what do we do, Doug? Posterior, anterior? I'm just messing with you. Just you can say anything. You can say send it to the spine surgeon. Rotator cuff repair?
What's the problem then? Pain?
Right dorsal forearm pain. Could be anterior interosseous nerve. Release the anterior interosseous nerve.
Just pain. I would
Pain.
treat him non-operatively. Give him a trial with anti-inflammatories and therapy.
Okay. Well, he went to see
him
his.
back in a week.
He went to
him
see
back
his.
in a month, rather.
Okay, he went to see a spine surgeon, so he got a C5, C6 ACDF. So tough
That
luck.
day.
Yeah. Okay, no, he failed non-operative treatments. Okay, next patient, Joanne, 75-year-old woman with left upper extremity pain and ataxia. What do you see in the X-rays?
so again, you've got some degenerative changes at 4-5, disc osteoid 4-5, 5-6, osteophyte formation, end plate degenerative stuff. It's degenerative stuff going on with the sets as well. But, nothing that impressive.
Okay, C5, C6, C6, C7, anterior osteophytes, maybe some posterior osteophytes. How about on the MRI?
So again, you have the disc osteophyte complex at C.
Hold on, I can't show that.
You can't show me?
Go ahead.